Um, it's um, it's an absolute pleasure to be here and to give the first talk. So as Liz mentioned, my name is Roxy Chis. I'm a gastroenterologist and I specialize in caring for patients with inflammatory bowel disease. So I'm very excited to go over today's presentation and hopefully teach you something. So I'll go ahead and I think share my screen. And feel free to interrupt me and ask any questions at any point. So can everyone see my screen? Sorry, I'm trying to, there we go.
Yep, we can see it just fine.
Okay,
yep.
Perfect. Okay. All right. Just a disclaimer, I am using these educational slides from the Crohn's and Colitis Foundation. And so you can see here the original authors. I have updated the slides to suit our purposes for today. But with thanks to these authors, let's go ahead. So today's objectives, we'll talk a little bit about recognizing the impact of IBD, talk about the pathogenesis of IBD. We'll specifically focus on clinical features, symptoms, and physical exam of patients with inflammatory bowel disease, because I know that is quite pertinent to today's presentation. We'll talk about how we diagnose IBD and initiating a treatment plan. And then lastly, I will discuss just briefly special populations that have specific considerations in IBD. What is IBD? IBD is a condition that's characterized by chronic, it seems to be immune-mediated inflammation of the GI tract. And oftentimes what we see is a progressive and destructive course in inflammatory bowel disease. We have identified two major forms of IBD, one of them being Crohn's colitis and one being ulcerative colitis. And although the two fall under the same umbrella of inflammatory bowel disease, they can have fairly varied clinical courses. And so we'll spend a little bit of time talking about that. Just of note, IBD is not IBS, which is irritable bowel syndrome. There are certain symptoms that can overlap, but IBD is an inflammatory immune-mediated condition, whereas IBS is more of a functional disorder. And so it's worthwhile making the distinction between the two because the treatment is vastly different. And the reason we're talking about IBD, or we focus a lot of our efforts on managing IBD nowadays, is that the incidence of IBD has significantly increased in time, over time in both the US and Canada. So in the US, we have an estimated 3 million people that live with Crohn's disease or UC. And in Canada, we do have a smaller population, but in Canada, currently we have over 300,000 people living with IBD, and it is projected that by the year 2035, it'll be almost 500,000 people with the condition. So clearly it has a significant impact on our medical population. What causes IBD? Well, we have done a lot of research in the field, and it appears that IBD occurs because of an intersection of multiple factors, including genetic susceptibility, immune responses, and environmental triggers. So with regards to genetic susceptibility, we know that IBD runs in families, and we've also been able to identify a number of genes that are linked to either Crohn's or ulcerative colitis. We believe that in IBD, there is a dysregulation of the immune response when it comes to bacteria that live in the gut. So normally, all of us are colonized with helpful bacteria that lives in the gut. And for the most part, our immune system just ignores that bacteria and allows it to do its job, which is to break down products of digestion. But in IBD, what happens is that the immune response gets overly sensitive, overly active, and it recognizes that helpful bacteria as an invader, which it then causes it to attack the bacteria, causing inflammation. And when this inflammation is not managed, it leads to chronic inflammation and then inflammatory bowel disease with all of its sequelae. And then environmental triggers, I think we have a little less data on what sort of environmental triggers are known for causing IBD, but we know that smoking in certain patients will trigger IBD. We don't know why, and we don't know which patients those are, but we do know that there is some component of environmental triggers that affect IBD. Let's move into the meat of things. How do we diagnose inflammatory bowel disease? So specifically looking at what our diagnostic goals should be, I remember I said that there is a difference between Crohn's disease and ulcerative colitis. And so our first diagnostic goal should be to distinguish whether this is Crohn's disease or ulcerative colitis that we're dealing with. It just so happens that about 10% of patients that have IBD don't fall into either category. And so they end up with a label of indeterminate colitis. And normally those patients will have features of both of the diseases. And another diagnostic goal should be to map the extent of the disease burden. You'll hear a little bit later about how ulcerative colitis can involve parts of the colon, and then Crohn's disease can involve anywhere in the GI tract. And so mapping how much of the gut is involved is important because it does influence our management. Other goals are to identify disease behavior, specifically for Crohn's disease. So I'll talk a little bit about the complications that occur specifically with Crohn's disease, and then recognizing how severe the disease is. And thus far, we don't have a gold standard test to diagnose IBD, and really we go off of the patient's clinical presentation, so symptoms, physical exam, endoscopy is very important, and any other imaging tests and blood work. So it's just a compilation of those that gives us the diagnosis of IBD. So what else should we think about when a patient presents with symptoms that are characteristic of IBD? And we'll talk a little bit later about this, but normally the symptoms include diarrhea that can be bloody or not, abdominal cramping, weight loss, fever. But normally when a patient presents with diarrhea, our differential diagnosis should always include infectious causes, specifically C. difficile. So before running any other tests, we always send off stools for cultures and sensitivity and ova and parasites. Ischemic colitis is also on the differential, so that's just lack of blood flow to the gut, specifically because, say, an episode of low blood pressure, whether that's because of sepsis or just low blood pressure. Sometimes you can get it in long distance runners because the blood gets diverted to muscles. Sometimes using anti-inflammatories can cause symptoms that are similar to IBD. Radiation to the pelvis in the setting of previous cancer. We talked a little bit earlier about IBS. So IBS will present with diarrhea. Very rarely will the diarrhea be bloody, whereas in IBD, it's a lot more common. Another diagnosis that's always on the differential and always needs to be ruled out is that of a malignancy or a cancer. Colon cancer in the later stages can cause diarrhea and bleeding. This is the proposed diagnostic algorithm for a first presentation of inflammatory bowel disease, so basically, like we'll hear later, it's really just a patient who presents with bloody diarrhea and abdominal pain. Normally, what we do is we start off with certain investigations that are just basic investigations, so looking specifically at a CBC. And things that we look at here are anemia, so low hemoglobin. In the setting of ulcerative colitis, for instance, they will get bloody diarrhea, they will lose blood, and so you will oftentimes see an anemia. The other thing that will pop up here might be a high white cell count. In Crohn's disease complications that occur are abscesses, so infections, and so that will drive up your white cell count. CRP or C-reactive protein, we always order that. It is a marker of inflammation, not specifically of the gut, but it gives us a very good indication if there is inflammation in the body. And then albumin. Albumin is important because it tells us about the nutritional status of patients, but also it can be an indication of inflammatory burden. So patients with ulcerative colitis who have a lot of inflammation will basically, when they have diarrhea, they're basically just dumping albumin. And so that just tells you there's significant inflammation, and so we're not holding on to our proteins. And then, like I mentioned previously, we do check stool studies for infectious causes. So everyone will get stool cultures and sensitivity, stools, ova, and parasites. And then calprotectin, which I don't know how applicable and how much access you might have to a fecal calprotectin, but it's basically a non-invasive marker of inflammation that's more specific to the gut. And so what it does is it's a stool test, and then it just measures white cell counts as a marker of inflammation in the stool. It's not covered by OHIP, and normally even here, patients do have to pay for it. And so oftentimes, if we have a high suspicion of inflammatory bowel disease based on other investigations, we'll go straight to endoscopy. So fecal calprotectin, you may consider it if you have access. If you don't, it's really not a deal breaker. And then we always go ahead with that, normally a colonoscopy initially. And then if we have a suspicion that this might be Crohn's disease, then we will do an upper endoscopy as well. The reason for that being that Crohn's is one of the two inflammatory bowel diseases that can have upper GI manifestations as opposed to just colonic. And then we can consider imaging of the small bowel as well for Crohn's disease, but not for ulcerative colitis. So let's talk a little bit about the distinction between the two, because you kept hearing me allude to this. But so like I said, they are similar in certain ways because they're both inflammatory conditions of the gut, but they are very different in other ways, and their management is we tailor management based on the actual entity, ulcerative colitis or Crohn's disease. So ulcerative colitis will involve only the large intestine, so specifically the colon and the rectum. And the rectum is always involved, so the lower part of the colon is always involved. And the inflammation that occurs in ulcerative colitis is more superficial than what we see in Crohn's disease. So it involves just the mucosa and the submucosa, so just the superficial layers, the lining of the gut. And ulcerative colitis also has a continuous pattern of inflammation. So starting in the rectum, and then it just extends proximally. So we can start in the rectum, involve the left side. It can continue to involve the transverse colon, or it can continue to involve the entire colon all the way to the cecum. But it doesn't extend past that. And oftentimes patients will be fine until they're not. They present acutely with bloody diarrhea, and they just abdominal pain, and they feel terrible. Whereas Crohn's disease, like I said, is more extensive. It can involve any part of the gut, of the GI tract. So we normally say from gum to bum. And the rectum is only involved in about 10% of cases, meaning that 90% of people do not have any rectal involvement, which is the lowest part of the colon. The inflammation also runs deeper than in ulcerative colitis. So it involves inflammation of the entire wall of the intestine. In patients where the rectum is involved, it actually can form abnormal connections with the skin around the anus, and that's called perianal involvement, and normally signifies worse disease course or progression, just a more severe type of disease. And Crohn's presents with skip lesions, so meaning that we have areas of inflammation that are interspersed with areas of normal gut. And patients will oftentimes present with grumbling symptoms where they're a little bit ill, but not acutely unwell. So they'll have abdominal pain, they'll start losing weight on and off. They might show obstructive symptoms, but less obvious than ulcerative colitis. And in Crohn's disease, oftentimes what we see is we will see diarrhea, but not necessarily bloody diarrhea. So that's just another distinction to keep in mind. So predominant symptoms of ulcerative colitis, so like I said, rectal bleeding. The reason for the bleeding is when we have inflammation very low down, so in the rectum, the lowest part of the colon, there will be bleeding. So the friability of the mucosa will cause bleeding. And since it's so close to the outflow, you will see it and you'll see bright red blood. Also, because the rectum is inflamed, the rectum is really responsible for maintaining control of your bowels. And so patients, because they can't really, because of the inflammation, they can't really sense and control release. And so they will have very frequent and small volume loose stools. Oftentimes we do see mucus discharge, as well as this feeling of incomplete emptying called tenesmus. When they have to go, patients with UC and rectal involvement really have to go. So there is a sense of urgency and running for the bathroom. And sometimes they'll get this rectal discomfort. And depending on the extent of inflammation, so if it involves more of the colon, so like I said, it can involve just the rectum, it can involve just the left side, or it can involve all the way to the right colon and then all the way to the end. Just depending on the extent of inflammation, they can get abdominal pain that's quite severe. So this is what I do is endoscopy. So colonoscopy, this is what we see on colonoscopy. So on the left here is what appears to be a diseased colon. So you can see that there is inflammation, that the mucosa just looks like very granular, like crumpled up paper. And then those white lesions at the bottom at 6 o'clock, those are ulcerations. And so this is pretty well a picture of pretty severe colitis. It's a moderate to severe. We can see even larger ulcers, but this is not a good looking colon. And then we normally take biopsies, and the biopsies help us distinguish between ulcerative colitis and Crohn's disease. They do look differently. They do look different endoscopically, but the biopsies also help distinguish between the two. So the pathologist will just look at the biopsies and will tell us if this has features of ulcerative colitis, which I won't go into. It's beyond the scope of this presentation, but we do have multiple tools available to us to distinguish between the two at every level, basically. On history, physical exam, endoscopy looks different, and then pathology also looks pretty different. So this is a score that we use for endoscopic scoring of the severity of ulcerative colitis. And basically, it's just a matter of looking at whether or not there are ulcers, if there's friability and bleeding, spontaneous bleeding. And so the score goes from 0 to 3, and clearly 3 is the most severe that we see. Just for reference, what we saw there is probably a 2. So that's kind of in the middle. So I thought I'd spend a few minutes here just talking about red flags in ulcerative colitis, because although Crohn's disease tends to have a more complicated course, ulcerative colitis can present very acutely and can have a very severe initial course where we need to take action. So these are things that we should keep in mind. So acute severe ulcerative colitis can be a life-threatening medical emergency in patients with ulcerative colitis. And it just so happens that about a third of patients, so a good 30% of patients, will present like this on their initial presentation. And so we need to keep that in mind and make sure that we don't miss this on initial presentation, because it can have some pretty serious complications. When do we suspect acute severe ulcerative colitis is when patients present with more than 6 bloody bowel movements in a day that are loose. So 6 bloody bowel movements, and then one of the following criteria. So a heart rate that's over 90, which is so just tachycardia, a fever, so temperature over 37.8, anemia, so hemoglobin of less than 100. These are just American units. And then an elevated C-reactive protein, which is what we talked about at the beginning. So if there's more than 6 bowel movements a day, and then any one of those 4 features, we should suspect acute severe UC, and those patients normally require inpatient admission. So most patients with ulcerative colitis and Crohn's disease can be managed as outpatients, but these people absolutely need to be admitted to hospital and monitored. And so we start off with our slew of laboratory investigations, which is what we talked about. So a CBC looking for anemia and elevated white count, an ESR CRP as a marker of inflammation, and stool cultures, like I mentioned previously. And then the other things that you see here under labs, if you're following along, is you'll see a test for hepatitis B, and then you'll see an IGRA for TB, and a TPMT. So all of those investigations are done in the event that we are going to need to start a biologic medication. And chances are that in patients who present this severely, we will want to start with basically our most effective and most potent drugs, which I'll talk about in a little bit. But these are patients that will need the big guns for. And so they get treated automatically with steroids. So intravenous steroids, Solumedrol, 60 milligrams. And then we automatically also get a surgical consult on these patients in the event that they might require surgery. So what we end up doing is we reassess their symptoms at day 3. As well as the laboratory investigation, specifically their CRP and hemoglobin, and we care about the CRP coming down, and hemoglobin ideally going up. But we want to see the inflammatory burden come down within 3 days. And if that's not the case, then these patients might actually need to go to surgery. So it's helpful to have the surgeons aware before actually needing to go to the OR. And so if there is no improvement or only marginal improvement in 3 days, that's when we start our rescue protocols, specifically biologics. So this is when you need a gastroenterologist to be involved, clearly. And they get intravenous biologics, and then we reassess again. We give them just a few more days, and then if nothing happens and nothing's changed, then these people do go to the operating room and they have their entire colon removed. That's basically considered a cure for ulcerative colitis, because now you've removed the entire area that can be inflamed. So that is pretty well the main acute presentation for inflammatory bowel disease that we really need to watch out for. So moving on to Crohn's disease, like I said, Crohn's disease can be very different, and it even within the entity of Crohn's disease, it can have various presentations depending on its behavior. So we can get inflammatory Crohn's disease, which, the name speaks for itself. It involves inflammation of the intestinal wall. And so when there is inflammation, we oftentimes will see significant abdominal pain, diarrhea, weight loss, maybe fever. If the small bowel is involved, then we'll sometimes see obstructive symptoms, so nausea, vomiting, inability to pass gas or stool, because the small bowel, once it becomes inflamed and narrow, you basically just get a stricture, and things just don't pass through anymore. When the colon is involved, or the large intestine, then you can get you do have a larger diameter, lumen diameter, but also you can get things like bleeding because it is more downstream, and so more easily to see active bleeding. And Crohn's can also come as a stricturing phenotype. So, when we get inflammation, and the inflammation can settle on its own, so we don't always, uh, and especially in Crohn's disease, we don't always know, like I said, it kind of has this grumbling presentation. So we don't always know that a patient has Crohn's disease. So what might happen is that they end up with all of these minor symptoms where there is some inflammation, and then the inflammation heals on its own. That's the nature of both Crohn's disease and ulcerative colitis. They can have this relapse remitting phenotype. So meaning that some people can just go into remission and at certain times without doing anything, but then it will flare up again. So that's normally why we treat, is to prevent those flares and the complications. But once the bowel heals, now it becomes like scar tissue and it becomes fibrosed. And so that is when we get narrowing of the intestinal lumen, and that can lead to obstructions. Then we can get penetrating Crohn's disease, which basically just means that the affected bowel can now form abnormal connections with other areas. So specifically, you can get bowel-to-bowel connections that are abnormal, called fistulas. You can get bowel-to-bladder connections, colovesical fistulas, and then you can get, like I was saying earlier, perianal disease, which is a connection of the rectum to the skin around the anus. So the stricturing and penetrating phenotypes of Crohn's disease are a lot more difficult to treat and manage, and we'll just talk about that in a little bit. So this is what the colon looks like in Crohn's disease. So you can see a normal colon on the left, and then you see here that the ulceration pattern is a little bit different, or a lot different rather, from ulcerative colitis. So you can see the deeper ulcers, and just it looks like the entire wall is involved, just looks thicker and just chunkier. And the last image is that of the small intestine, so the terminal ileum, which, as I said, is normally not involved in ulcerative colitis. We would only see this in Crohn's disease. This is just the score that we use as endoscopists to rate the severity of Crohn's disease. So it's called the simple endoscopic score, a CSCD. It's not simple at all, but it focuses on the number of ulcers, the depth of ulcers, like the size, and then the affected surface area. And it basically takes that into account for every segment of the colon, and it basically gives us an indication of how extensive the disease is, which guides our management. And like I said, there are pathologic differences between ulcerative colitis and Crohn's disease. So specifically in Crohn's disease, we see granulomas, which in ulcerative colitis we do not. But anyway, a talk for a different day. So another interesting thing about Crohn's disease, and IBD in general, both ulcerative colitis and Crohn's disease can present with these extraintestinal manifestations. They do occur more commonly in Crohn's disease, though. And so oftentimes when we see this, we normally assume it is Crohn's disease. So patients with Crohn's will tend to get these aphthous ulcerations, or ulcers inside the mucosal surfaces of their mouths, which can be quite painful. And these normally tend to mirror disease activity. So if they have active Crohn's, they will have these sores that are active as well. Image B, what you see there is what we call sweet syndrome, and it's basically just an infiltration of white cells in the skin, causing a rash that can be pretty itchy and uncomfortable. Image C depicts erythema nodosum, which are just these painful subcutaneous nodules that normally occur on the shins of patients. So just the extensor surfaces of the legs, and the nodules really are quite tender. D and E are basically the same presentation of ulceration. One of them is on the leg, and then picture E, you see that around a stoma site. So that's called pyoderma gangrenosum. It's this awful manifestation of extraintestinal manifestation of Crohn's disease that's very difficult to treat. And again, it tends to mirror disease activity, but a lot of the times, like patients who have extraintestinal manifestations will need our big guns, and so definitely need to see a gastroenterologist. They can get eye manifestations, so you can see in F and G, there's scleritis, so the white of their eyes turns red or like inflamed. And then G, I believe, is uveitis, which is inflammation of the eye. And the rest of the images are pretty well showing joint disease. So we can get involvement of joints, both the spinal joints, so the SI joints, but then also peripheral joints as well. Again, as soon as joints are involved, these patients do need our big guns. So let's chat a little bit about treatment. When we decide on initiating treatment, we determine the appropriate treatment based on a few characteristics, and those are IBD-related characteristics, but also patient characteristics. So IBD-related characteristics, I spent a lot of time talking about the inflammatory burden, so disease activity, or just how inflamed these patients are. Disease severity, and so disease severity will basically how much of the gut is involved, and then how actively inflamed is it, whether or not there are complications of IBD. So this mostly pertains to Crohn's disease, so abscesses, fistulas, possibly strictures. And then if they've been on a prior treatment, that will influence what we pick as the next step. And then, non-IBD characteristics: are the patients actively infected? Have they had a previous malignancy? That will, and then how comorbid are they? That will also influence the type of medication that we pick, because as you'll see, we have some that have fewer side effects, and then we have some that come with full-blown immunosuppression to suppress that inflammation. So as I mentioned previously, disease activity, you basically learn that from the patient. So they will tell you how many symptoms they're having and how terrible the symptoms are. We use all of these scores, but really it comes down to a few things, which we'll talk about in a second: diarrhea, abdominal pain. So I'll touch on those in a bit. And then inflammatory burden will also tell us how active the disease is. And as I said previously, we can use non-invasive markers like a CRP or a fecal calprotectin to tell us how much inflammation there is, or we can look endoscopically. And then disease severity, we do have certain phenotypes that have more of a potential to have a more severe course, and I'll talk about that. So just some patient characteristics that will predict a worse course for both Crohn's and UC. So these are basically our the questionnaires for patients who present with ulcerative colitis and Crohn's disease to assess disease activity. So as I mentioned previously, it mostly focuses on how many bowel movements we're having in a day, and how many at night. And the number of bloody bowel movements. And then urgency is a big deal in ulcerative colitis because it depicts rectal involvement. And so how often do they need to run to the bathroom, or if they have accidents. And then if there's how well they feel overall, and any extraintestinal manifestations. And you can imagine this is somewhat subjective. A little bit of it is objective, the number of bowel movements and how many bloody bowel movements there are, but a lot of it is driven by the patients. So they will tell you how active their disease is, and we should listen to them. They're normally very right. And then for Crohn's disease, it's the questionnaires are a little bit different because the manifestations are a little bit different. And so, as I mentioned previously, they can present with abscesses or abnormal connections between bowels. And so here too, we ask about well-being. So generally how well they feel compared to their normal baseline when Crohn's isn't active. Abdominal pain, again, diarrhea. And then abdominal mass is, reflective of an abscess or a stricture. And then complications, so strictures, fistulas, perianal disease. So all of that gets taken into account to assess disease activity. I did say that there is a number of risk factors that will predict more severe disease. For both UC and Crohn's, an early age of diagnosis will tell us that they're going to have a more complicated course, unfortunately. For UC, if we have more of the colon involved, will be a worse prognosis. Severe disease when we look endoscopically. If they've required hospitalization for colitis. So remember how I was saying normally a third of patients present with acute severe UC where we need to hospitalize them and treat them with steroids. So that will normally predict a more severe disease course. And an elevated CRP, which is reflective of inflammatory burden, and then low serum albumin, again telling us there's more inflammation because they're dumping their albumin. And then in Crohn's disease, extensive anatomic involvement. The reason it says anatomic is because you can get the entire gut that can be involved. And then perianal disease. So I don't know if you remember, but I said that only 10% of patients with Crohn's disease will have rectal involvement. And that tends to be a bad prognosticator because it can form connections and perianal disease. That's normally very tough to manage. Deep ulcers on endoscopy. If they've needed resection of a part of their bowel because of, say, narrowing or fistulas or abscesses, then that too will predict a more complex course. And then stricturing or penetrating behavior. So what are our goals when we treat patients with IBD? Well, what we want is to turn off the inflammation. So you want to turn off the immune system and the chronic inflammation because it's the chronic inflammation that, gives the symptoms and then also the risk for these complications, as well as risk for long-term complications such as cancer, as you'll hear in just a little bit. So our goal is clinical remission. So meaning we get the patients in symptomatic remission, their symptoms have resolved. But that's not enough because more often than not, patients' symptoms do not correlate with what their insides look like. So what we want is we want the mucosa to heal. And that's been our goal for a number of years. And this is why we've developed so many medications recently, all with the goal of healing the mucosa. And so a lot of the time when we make changes in treatment, we will look inside to see what sort of response we're getting and if there is decrease in inflammation. And the third thing that's really important is we want to achieve all of that, but without using steroids. As I mentioned previously, in the short run, in order to settle the inflammation, we do use steroids, and they're very, very effective at settling down the inflammation for the most part. But long-term use of steroids comes with many, many side effects, and so we don't want to keep patients on steroids for long. And then once we've achieved all of that, we want to maintain it. So people go into a maintenance regimen with medications, and then we monitor for recurrence of disease and we monitor for complications. I can tell you this here is normally patients with active inflammation in the colon are at higher risk of colon cancer because that active inflammation can cause precancerous changes in the lining of the gut, and then those can progress to cancer. And so we oftentimes will look inside just preemptively to make sure that we detect some of those changes so that we can remove them to ensure they don't progress to cancer. So just really briefly, why do we care about the mucosa healing? Well, and that, like I said, it's what we target when we get patients on treatment. And oftentimes, like I said, symptoms do not mimic clinical activity. So sometimes people can be completely asymptomatic or mildly symptomatic, but then when you look inside, they have rampant inflammation. And so before we make any treatment decisions, we look inside. And we do have a number of studies, and like I said, a lot of medications that have come out in order to help us achieve mucosal healing, because we know that having healed mucosa decreases the likelihood that they'll have a flare, decreases the likelihood of complications like strictures, fistulas, and it also decreases the need for having further surgery, specifically decreasing the likelihood of cancer. So our treatment options, we talked about steroids. So steroids are very effective in the long run to induce remission, but we never want to maintain patients in the long run on steroids because of the side effects, which you can see down below. They come with run-of-the-mill sleep and mood disturbances, but you can get hypertension, you can get diabetes, you can get osteoporosis, loss of muscle mass, glaucoma, and steroids are immunosuppressants, and so they do increase the risk of infection. So we don't want to keep patients on long-term steroids. Budesonide is more of a locally acting type of steroid, so in theory, it shouldn't have the same systemic side effects as steroids do. But I have seen just my personal practice, I have seen even mood disturbances with and more systemic side effects with budesonide. So don't always trust that every patient will respond as they're meant to. It's never textbook. And then 5-ASA medications or aminosalicylates, which we only use in ulcerative colitis, not in Crohn's disease. Very good drugs for mild to moderate ulcerative colitis. And I used to prescribe them like tap water because, they don't really have side effects. I mean, there's a small chance of kidney injury, but very small, and just some GI upset. Some people can get paradoxical diarrhea, in which case you just stop the medication. However, the one thing that's not down there is a risk of pancreatitis. And this is very real. In the last couple of months, I've treated patients, very young patients, and I wanted to spare them steroids. So I put them on 5-ASA, and they both ended up with pancreatitis. And so pancreatitis can have, thankfully for them, it was a very mild and uncomplicated clinical course, but for some patients, it can be very severe. And so just keep that in mind when if you end up prescribing or you're monitoring patients who are on 5-ASA, who present with, say, some abdominal pain and they don't seem to be tolerating the medication. Always keep in mind pancreatitis and order a lipase. And then for moderate to severe IBD, we have a lot more treatment options for that now. We do have these drugs called immunomodulators, called thiopurines and methotrexate. Thiopurines we use for both Crohn's disease and ulcerative colitis. Methotrexate we use for Crohn's disease. Both of these are oral, and then methotrexate you can give intramuscularly. And then we have the biologic medications. And like I said, we only used to have the anti-TNF agents for years and years and years. So they were the only biologic available, multiple agents in that class, but the only class. And then in recent years, we've now had different mechanisms of action for these medications. And so I'm not going to go into any detail, but basically it just allows us to pick a different first-line agent for patients with more severe disease. And then if they fail one drug, we just have other options to move on to. And then in the last 2 to 3 years, we've come up with these oral medications, which has been quite the game changer because all of the biologics have been intravenous or subcut, whereas now we have tofacitinib and we're missing the upadacitinib. So these medications are oral drugs, and they work quite well, and we can use them even in acute severe UC as a medication. And of course, they come with their own side effects. And I think I have a slide at the end that tells you what to monitor if you have patients on these drugs. But a lot of the times, your gastroenterologist should tell you exactly what to monitor because they do have different side effect profiles. But I do have that slide for your reference. Or it's actually right here. Just the possible side effects, which I won't go through, and then there is a slide at the end with things to monitor. So when do we resort to surgery? Because surgery can be a treatment, like I said, in IBD. It just so happens that about 10 to 20% of patients with ulcerative colitis will require surgery, and that's normally in the setting of acute severe UC, just failure to respond to medication, so continued severe inflammation. And in UC, this is actually a cure. So patients will have their colon out and they'll have a stoma, but no more active disease. So it's pretty well the only cure that we have for UC. And then a lot more of Crohn's patients will require surgery, so almost 70%. And that's because, as I was mentioning, it does tend to come with more complications, more stricturing, fistulas, abscesses, and those are all things that can require surgery. When do we refer patients for surgery? Dysplasia or cancer. So dysplasia just means precancerous changes, which is what I was saying we monitor with colonoscopy. So if we see that, it used to be that everyone would get their colon out, but now we have very good endoscopic ways of removing any precancerous changes. So it's not an all or nothing right now, and we do have better outcomes for patients. If they have active disease despite treatment or not being able to tolerate medications for their disease, and then complications, as I mentioned previously, are all indications for surgery. So it's very good to have a friendly surgeon nearby. So very briefly in the last 30 seconds, so special populations in IBD, pregnant patients. So oftentimes what we'll recommend is that patients are in complete remission before they get pregnant. That means asymptomatic from a clinical perspective. That means their colonoscopy needs to look good. And then even on biopsies, we need to have lack of inflammation. And that basically predicts success of pregnancy and decreased risk of adverse events, so low birth weight or stillbirths. Having good control of disease is very important prior to pregnancy. Elderly patients, the reason we care about that is because we want to minimize polypharmacy. And then again, as I was saying, steroid use, especially in the elderly, can be associated with risk of fractures, osteoporosis, things like that, cataracts. And then patients with prior malignancy. So most of the medications that we use are big guns, the biologics. They all work by suppressing the immune system, or most of them. And so if someone has had a malignancy, you want that immune system to not be suppressed, to watch out for other cancers. A lot of the times that will influence the type of agent that we use in these patients. We do have some biologics that are more confined to the gut, so they don't have systemic side effects, meaning that we're more likely to go for that medication, specifically vedolizumab or Entyvio, because of the decreased risk of malignancy recurrence. So basically patients with IBD do require a lot of care and comprehensive care, just team-based care. Everyone gets vaccinations prior to starting, say, a biologic, but just overall, patients with IBD should have their vaccinations, and you just have a little reference here. But then in terms of health maintenance, and you're gonna get that in your notes from the gastroenterologist, they should absolutely tell you exactly what to do. But all women who are on immunosuppression, so meaning on a biologic, should get a yearly pap smear because they are at higher risk of cervical cancer. Everyone on immunosuppression should also get a skin exam every year because there's a higher risk of melanoma and non-melanoma skin cancer. And then, as I was saying previously, colonoscopies, which we'll normally arrange. If they've had disease for more than 8 years, is when we start caring about the risk of pre-cancer and cancer progression. And so that is when we'll do colonoscopies, not necessarily to assess disease activity, but to look for these precancerous changes. And we'll do colonoscopies every 1 to 3 years, depending on how active the disease is. But again, we keep track of all of that. And then DEXA scans because of the risk of osteoporosis, because of malabsorption, but also because of use of steroids. And then we do the TB skin test or IGRA. That's before initiating a biologic. So again, your gastroenterologist will tell you that. Everyone should quit smoking no matter what. And you know, in our history, we normally address that. And it can, you know, having IBD can have significant impacts on the mental health of patients. And so doing a depression check every year or every 6 months or so is really very important. So really briefly, we talked about how big of an issue IBD is in Canada and the US. We talked about diagnosing IBD based on symptoms, physical exam, and then some endoscopy and laboratory work. We talked about choosing treatment for IBD. A lot of it will be done by the gastroenterologist, or all of it, but there are some tips on what you might need to monitor or keep an eye on the last slide. And then when we treat, what we want is to decrease symptom burden and try to achieve mucosal healing, but definitely try to keep patients off long-term steroids. Preventative health measures are very important, as well as ensuring collaboration with the multidisciplinary team is really quite important. So these are just some resources that you might find helpful, some links, and that's it. Thank you so much for having me, and I'd be happy to take any questions if you have them.
Thank you so much. Okay, we got one in the chat about, can you briefly touch on diet, what to avoid, or alcohol consumption?
Diet, we do have some evidence that diet is important as an adjunct to medical therapy in inflammatory bowel disease. There are some studies right now where we're looking at just dietary interventions as a sole treatment modality for mild IBD. I think once we were in the realm of moderate to severe, it's more difficult to treat with just dietary changes, but truly what we know so far is that just general common sense is what we follow. So we try to decrease the intake of processed foods. Patients will tend to feel less symptomatic if they avoid dairy and sometimes gluten, because that can cause superimposed symptoms on those of IBD. Avoiding smoking, avoiding alcohol, or at least, you know, moderating alcohol consumption. There's no hard and fast rule about that. And then what we always recommend is pretty well a Mediterranean diet that's mostly plant-oriented and fewer animal products is what seems to be most healthy for the gut in IBD.
Perfect, thank you. Any more questions from you guys out there? That was really informative, thank you.
Okay, I'm glad. Well, thank you for having me, and feel free to reach out with any other questions.
Perfect. Okay, I'm just gonna steal the screen share for a second.
Okay.
Hold on, I'm just gonna open up what I need. And we just wanted some feedback from everybody on these sessions. So I'm gonna share my screen. All right. Can everybody see that QR code on the screen?
Yep, we can see it.
Perfect. Okay. Take your phones out, ladies and gents. Please scan the QR code and leave your feedback if you can, if you want these wonderful sessions to continue and if you want them tailored to your learning needs. So a lot of these sessions are based on this year, are based on the feedback you gave last year. So if you'd like to see more of something, less of something, there's a specific topic you feel like is you're seeing a lot in your practice, please put it in the chat. This just helps us learn together and grow as much as you can.
Yeah, the QR code.
Yes, so just scan it with your camera on your phone and it should take you to a web page with a feedback survey. Okay. I will take this down in a couple seconds. Okay. All right. Thank you so much, Dr. Chis. We really appreciate being here.
Thank you for having me. Have a lovely day.
Thank you.
Bye.